So another abstract we presented at this meeting was the impact that prior bendamustine exposure had on patients receiving CD20, CD3 bispecific antibodies. We collected data on relapsed refractory large B-cell lymphoma and follicular lymphoma patients from different Spanish centers who had received bispecific antibodies, and with a percentage of them had been exposed previously to bendamustine. Interestingly, with the data coming from the CAR T-cell setting, where we've seen in the mantle cell lymphoma, follicular lymphoma, large B-cell lymphoma setting that bendamustine has a negative impact, we kind of expected to see the same thing with bispecifics, given that they share a similar mechanism of action with CAR T-cell therapy, but surprisingly we did not see the same signals. So we observed both in large B-cell lymphoma and follicular lymphoma patients similar outcomes in terms of toxicity, in terms of response rates, in terms of survival between benda-exposed and benda-naive patients who were being treated with bispecific antibodies. So this is definitely thought-provoking. We have to look further at larger cohorts of patients before moving this forward, but we definitely think it's very important data in the era of sequencing, all these novel options, and considering that it has a negative impact before CAR T-cell therapy, maybe moving forward with bispecifics, in patients who have been recently benda-exposed could be an option. But again, we need larger numbers, and especially larger numbers with patients who were recently exposed to bendamustine, because there were a small amount of patients, like only 5 patients, who had been exposed within 6 months to bendamustine before bispecific antibody therapy. So, I think that's the biggest question. What about patients who had a recent exposure? So gathering more data on patients with recent exposure and with exposure in general, I think we can fully answer this question, in a future manuscript.